Good afternoon, everybody. Welcome to Greater Columbia Accountable Community of Health Learning Collaborative for Social Determinants of Health. Please be sure to log your name and your organization into the chat box. Presentation will begin shortly. And our presentations, minutes, and meeting recordings will be posted on our website at www.gcach.org and on the CSI portal. All right, give it a few more minutes before we get started. Okay, if you're just joining us, please be sure to log your name and your organization into the chat box, and we will be starting shortly. All right, it's 2:03. We're going to go ahead and get started. Again, welcome to Greater Columbia Accountable Community of Health Learning Collaborative. This one is on social determinants of health. Please be sure to log your name and organization into the chat box. The presentations, minutes, and meeting recording will be posted on our website at www.gcach.org and on the CSI portal. If you have any questions, please make sure you post them in the chat box.
Hi, everybody. This is Laurel. As Brittany said, today we're going to be talking about social determinants of health. Particularly, we are going to be talking about screening for and addressing the social determinants of health. We want to introduce our practice transformation team. We, first of all, would like to introduce Sam Wardell, our Director of Practice Transformation. Sam wants to say hello.
Hello, everyone. Thank you for attending our learning collaborative.
And Brittany Fox-Stading and myself, Laurel Avila, will be presenting today. We're missing Martin Sanchez, our third navigator, and he's on leave, but we're looking forward to his return on May 24th.
So for today's agenda, we're going to start off by an icebreaker activity. We will then roll into the introductions of social determinants of health, and followed by going over social determinants of health screening tools, how to collect data and best workflows, the importance of referring and closing the loop, We will then move on to discussions of community resources. We will then have a short break, and when we come back, we will go into breakout rooms to share and discuss based off of the specialty that you're in. And then we will wrap everything up by sharing in the group and finishing with an evaluation. So to start off with, we're going to go ahead and do our icebreaker poll. So your poll should be launching on your screen. Go ahead and answer the questions. Okay, we're just going to give a few minutes for everyone to go ahead and finish, and then we will share our results. All right. Just going to give a few more seconds for everyone to finish. All right, I'm going to go ahead and end the poll, and then we'll go and we will share the results. So for question 1, do you regularly get a lunch breakout work? And almost always or sometimes, so that's actually really, really good. It's happy to see that. Okay, how do I?
And we're really sad for that one person that doesn't get lunch ever. That's terrible.
And then I'll have to do one more. All right, this one's kind of interesting. We have, do you get your annual physical exam? And it's about a 50-50 split. And I'm just going to go ahead and do one more poll real quick, and then we'll move on. Going to go ahead and end this one, and we're going to share results. And this one was just for fun. Do you have a pet at home for your emotional well-being? Looks like most people said yes. So the reason why we wanted to share these is that it all kind of ties in together. Our social determinants of health, they really do impact our health and our well-being, and it's really important for us to make sure that we're keeping that in mind. Like I said, these ones were for fun for us to, kind of see that importance. But as we go into this, the social determinants of health, I know that you guys have seen, it really does impact our patients' ability to be the best that they can for their overall health and well-being.
Oh.
Laurel?
Yeah, I was just noticing it. Sarah couldn't hear, so I was hoping we could do that. So social determinants of health, what is it? I looked at the World Health Organization to see how they defined social determinants of health. So then they define that as the non-medical factors that influence health outcomes. They are conditions in which people are born, grow, live, work, and age, and the wider set of forces and systems shaping the conditions of life. Next slide, please. So again, kind of thinking about more specifically, this slide we have taken from Healthy People 2030, the U.S. Department of Health and Human Services, and they've looked at it by looking at these categories: healthcare access and quality, neighborhood and built environment, social and community context, economic stability, education access, and quality of education. So when we think about this is just one way. There are many, many sources out there that are looking at social determinants of health. And I think what's helpful is for us to kind of think about a situation. So what I'll do is talk to you and give you an example of why we are looking at this, very simply stated. So just a patient that would come in and see their provider in a primary care clinic, for instance, and they presented and had high blood pressure, obesity, and diabetes. And so this provider, after assessment, makes a plan, and that includes having medications and explaining the medications to the patient, and education on a diet, and even makes a referral to a diabetic educator, and then talks to the patient about starting to exercise, even just a few minutes a day. So when they leave, they have their plan, and the provider says, okay, well, let's just go ahead and follow up in 3 months and see how things are going. So at that 3-month follow-up appointment, the patient may or may not have been successful in that. But let's just look at that situation of that nothing changed, or even perhaps got worse. So the provider has this going on a regular basis, and they're like, I just don't know. I don't know what I'm doing. I don't know what else I can do. I have these plans. We have great medications. I made that referral, everything just, I'm doing everything I can in the few visits that I have with this patient. And what we've seen in the past years is just that frustration sometimes of like, what else can I do? I'm missing the mark. So studies over the recent years have been looking at this concept of social determinants of health. So, if you will, the upstream effects of our context that we live in, where we were born in, and the things that we're experiencing in our lives, and considering those and the impacts that they have on our overall health. Makes it pretty hard to think about, one person, one provider trying to address those. But what we really want to do is think about, well, okay, with this patient, consider, was that educational materials that I provided and offered, was that culturally appropriate and at the right educational level? Did the person have the ability to pay for those medications? Maybe they never picked them up and they didn't even share any information like that. Does a person have a home? I've asked them to exercise, but they don't know where they're going to sleep tonight. So it's easy to see how these things that we've identified as social determinants play into the overall health. And until we try to begin addressing them in some fashion, we really need to look at that larger context with our whole community. It can't just fall on one entity, but as we learn to look at things together and try to come up with solutions to address the social determinants of health that might have come up for each patient in there as a need. Next slide, please. This is another look at some of the domains of patient need. This actually comes from the Centers for Medicare and Medicaid. They identified 5 areas or domains of need, and housing instability, food insecurity, transportation difficulties, utility assistance needs, and interpersonal safety. One of the things that we've all been working on together is identifying identifying the social determinants of health and using them to risk stratify our patients. One of the difficulties is just deciding on a screening tool. So I wanted to bring this one up as an example of something that's out there, and we'll go to the next slide. This is a tool that was developed by the CMS and in context with a team of people. They came up with 10 questions. They've met together with the team to come up with a wording because it is difficult to come up with wordings. You always want to be respectful and have them not too difficult or not too hard to understand. And then they also wanted it to be done in a context in a very busy clinical setting that you don't want to take up too much time from that visit with a patient. So I'm not going to read it to you, but I just want you to see it. And we have this available to you as a resource. So go ahead and go to the next page. That's just the up to the 7th question of this screening tool. And then through to question 10, and they have a scoring mechanism for that. So that's just one of the types of screening tools that we have out there. We haven't come up, as you all know, because we've been talking to you, we haven't come up with one that we want you to use. We just want you to start somewhere. We'll get into that a little bit later. But I also wanted to go ahead and discuss another screening tool that I've seen others in our providers using. So next slide. So the PREPARE tool, so protocol for responding to and assessing patients' assets, risks, and experiences. For this PREPARE tool, there is actually, we've put into our resources folder in the portal, the tool kit that goes along with it. I think it's 132 pages, so quite comprehensive. And then the tool itself, this was the printed version of the tool, and it's just 2 pages. So I just have that here as a visual, so you would know, and those of you who may not be as familiar with it, what it actually looks like. Okay.
All right, so these, like Laurel said, that was just a couple of the tools that we have. But when dealing with social determinants of health, it can be quite overwhelming to start off with. So one of the things that we wanted to provide was a space for you guys to be able to share and collaborate with each other. So we have actually created a folder on our CSI portal for you guys so that you can do just that. And we actually have some of them already uploaded. So I'm going to go ahead and show you where to find those. So you go to our main CSI page. On the top banner, you're going to click on the resources tab. And then under the resources tab, once it loads, there is a social determinants of health folder. And in that folder, this is available for all of you that have access to the portal. You can add in any of your own resources, screening tools, and then we also have this community resource tab here that you can put in community resources that you guys can share. I do want to go ahead and share one of them. This one is from PMG. So this is a beautiful screening tool that they have uploaded onto the portal. So you guys can have access to that. So it's a beautiful, nice picture. It's very easy to understand.
And is Becky Betts on? Because this is one that they're using. I don't know if she had anything she wanted to add about that.
All right, and then we also have the community resource list. There's nothing in here yet, but we do hope that you guys will feel free to use this and share amongst each other. So that way you guys, not everyone's having to reinvent the wheel. So best practice is to share and collaborate. Okay.
And so I'm thinking this is familiar for most of you. This is the risk stratification component of our reporting that you've been looking at, especially in the last, pretty recent past. One of the things that we added in year 2 was to have social determinants of health as mandatory for part of your screening when you're looking at your risk stratification methodology. So it's important to realize it's there, but this is why we were wanting to talk about it during this learning collaborative. It's like, okay, it's there. What do we do with it? So I think everyone is doing this in some form or fashion, and we're very excited that we started down the road. So we are hopeful that what we cover today will help you have some concrete steps to take towards doing this in even a more comprehensive way than you may be doing already.
All right. this can be a little overwhelming. I'm sure that some of the schools or the tools that you've seen, there's a lot of screening that can be done. So first I ask everyone just take a breath, take a break, practice the pause, and then just break it down into simple steps. So this is kind of the identification that I came up with and I've worked with some of my sites on that I feel is the most beneficial to do. The first thing that I always encourage you guys to do is to really look at your communities. You guys know or have a pretty good idea of what the challenges are with your patient demographic and your unique needs in your community. So with that in mind, I would look at what the potential social determinants of health challenges are in your area for your organization. And just start with just 3. Don't try to take it all. Just start with 2 or 3 to screen with to begin with that you want to work on that you feel are the most important and impactful to your area for your organization. Next is, I really encourage, it'll make everything much easier if you guys can incorporate it into your electronic records. So the EMR system that you use, that really is the best practice and it will make your life a lot easier with following up on the social determinants of health once the patients are screened. So with that in mind, the first thing that I always tell people to do is, check in with your IT team. Your IT team is your best friend. And you want to just check in and see, what are the capabilities? Where could it potentially be added into the EMR for your screening? What would make the most sense? There are limitations on the EMR, so I would always start with that first so you can kind of have an idea of where it could potentially go before you bring in the team to decide what the workflows will be. So with that also in mind, when you're talking to IT, you want to be able to ask them, how can we pull this data out? How can we capture it? Where also in the EMR, not just the documentation of the screening, but also where can I pull this data out so that we can see when patients are screening high for housing needs? That will be a really helpful and useful report when trying to follow up on these patients that you're screening. Once you've got that, you have a good idea of what your EMR is capable of, what the limitations are, and how you could potentially be pulling that data. That is then when I would pull in your care team. So that is the people who are actually going to be doing the work, those that are going to be working with your patients and doing the screenings. You want to get them involved in establishing the workflows. And you want to do that for 2 reasons. One, the most obvious is that they're going to know best what's going to be capable to blend in to their current workflows that they have. So, and then secondly, you want to get that buy-in. It's really important in order to have sustainable workflows to have your staff say, yes, this is doable. I see the importance and we're going to make a difference. It's really important to have them feel like they're a part of that process. And then once you've got the workflows established and you're starting to capture that data and screen for those patients, you want to go ahead and the next step, and it's the last step, and it may take a little while, so don't feel like you have to do it right away, but eventually the goal should be to try to apply those social determinants of health screenings when they're test positive, like they say they have a housing need. We want to go ahead and figure out how we can blend that in and add that to your risk stratification methodology. So maybe, for example, a diabetic patient who has an A1C of over 9, maybe that alone isn't enough to put them in for a care management for your team members. But maybe if they have that and they're also experiencing, homelessness, maybe then that throws them into that risk stratification of that highest risk stratum and somebody can be following up with them. So it's kind of combining those factors into the risk stratification methodology. On this next slide, I wanted to share, this is an example of one of the screening tools. This is actually brought to us courtesy of Lord's Health. This is their primary care practice, and they screen for housing, food, and safety. So this is a great example. They chose 4, which is perfect. It's in the EMR, it's under their orders. They're able to pull reports on this. This is a great example of how this ultimately where you would like to see your screening for your social determinants of health go.
So just as Brittany was saying, it's important to really gather the team and when establishing the workflows. So important. We wanted to draw it out here on another slide. The work that you put in up front really does pay off when you start trying to begin screening for social determinants of health. Of course, you don't have to have every detail figured out as far as, things are going to not really flow sometimes. But we want to make sure that you've prepared yourself. And as Brittany said, that really helps, when someone has a part in establishing a workflow or coming up and defining a workflow to get buy-in. They're like, oh, okay, I think this is going to work. I actually had an opportunity to weigh in on this. So I wanted to capture like thinking about everything. So you want to really think about who. Sometimes, someone at a higher level, when they go and chart out a workflow initially, they may not remember. It's like, oh, that's right. This person touches, that piece of work. So for example, your front office staff, if you've come up with a beginning point of having a paper that someone is looking at to fill out their social determinants of health and answer questions, then that handoff would then go to a medical assistant that's rooming a patient for bringing back the patient into the room and gathering information. So make sure that who, like everyone, even, throughout your organization. I know we haven't talked as much about workflows with our behavioral health sites, but those workflows sometimes include the same, the registration person. And then, as far as the clinician who may be doing an assessment, an initial intake, they're gathering a lot of this data. So, working with that clinician to say, okay, what do you think about this process, and incorporating them and establishing that workflow so that they can remember to do it and follow up with someone when something's been identified, and not needing to try to do everything themselves. So who, what, so, what exactly it is, if it's a piece of paper, if it's a piece of paper and, a field and your electronic medical record, where, so you want to remember to think about, okay, so it starts, out in the lobby, or it starts on a telehealth call with the person that when they make their appointment. And so that kind of, if you remember all the where of these things that take place when you're having your patient interactions, when and how, and then closing the loop. So this is a big part of talking about this topic, and essentially quite challenging. So we want to spend some more time on that. And so we'll go ahead and move to the next slide.
All right, so the importance of closing the loop. This is probably the most challenging when dealing with social determinants of health. So hopefully the next few slides will help with that and identifying a best process for your guys' organizations. So obviously the first part is after you've done your screening, you've identified a need. And again, I just want to remind everybody, if you haven't started screening yet, start small. Don't try to take on too much too fast. Start with just a few to begin with. It is a domino effect. I have found that once you start, it begins easier to add things in, and that's okay. So just remember to start small. That's all right. Using community resources, that is going to be the biggest need. A lot of what we're seeing for people screening is food insecurity, housing insecurity, and safety. Those are all really great ones to start. It seems to be a common need amongst many of the communities and organizations that we're working with. But like I said, you can choose your own, and we encourage you to do that focused on your individual community needs. So we will be sharing some community resources with you here in just a little bit. One of the things that will help with your social determinants of health and really closing the loop is starting a formal referral process. So many of these community resources, they may not have a formal referral process set up yet. I would really encourage you to try to use your collaboration and your community resources to try to set something up. It will help when following up on your patients to make sure that the care that they needed outside of the medical care was actually able to see fruition. So like if they needed housing assistance, you know, being able to have somebody reach back to you and say, you know, you referred John Smith, but, you know, he never showed to his appointment to fill out the paperwork so that he could have housing assistance. Like those are really important things. And I know a lot of our communities, they're very small. And so I'm hopeful that those formal referral processes can be put in place. And which really ties into the next piece, the follow-up on the referrals, being able to have those relationships within our community to have them reach back out to us and say, just that, you know, John Smith didn't come in for their paperwork, so we weren't able to help them. That way we can all work together. And then this pulls into really why we were promoting the community health worker. So the community health worker, if you are fortunate enough to have one with your organization, this position really does help with that referral process and also being able to follow up on those referrals, in particular with those social determinants of health. A really great program. I know that you guys have read about it, so I'm not going to go into too much of it, but that is really a key piece that will really help in closing the loop for any of your patients that do screen for a need in social determinants of health. So with that, the biggest thing is being able to see the outcomes and the benefits, and then being able to share that with the staff. It doesn't take long. I know you guys have probably been on one of the ones where we had Becky that's from Providence. She's actually had a community health worker now for over a year there, and she keeps on adding more to her team, which is amazing. And the stories that she has to share are phenomenal. So once you start with this, it is very quickly, you will be able to see the benefits and the health outcomes in your patients.
And I just want to add to on that one, Brittany. So in all of your health outcomes, kind of like where we started when we were discussing why screen for social determinants of health. So, you know, if we can, as a community, come together to address some of these needs that are showing in our communities over and over again, you know, we're hoping to really be able to improve outcomes. So as we work to try and identify the outcomes and track them, we're hoping it'll be quite inspirational to see the improvements that we're able to make in a patient, an individual person's overall life and well-being.
So with the screening tools and part of closing the loop, I'm going to hand this over to Wes, who's going to touch base real briefly on the community information exchanges.
Brittany, thank you very much. Can you all hear me?
Yes.
I just want to talk a little bit about community information exchanges, and this is the architecture that some communities and some organizations have put into place. Before I do that, first of all, this slide and the next slide came out of a presentation that we gave at the recent Leadership Council, which relates to a very large project area that the Greater Columbia has thought a lot about over the last several years and is slowly moving into with collaborations across the state with other ACHs who are farther along in this process. It is very technical and it's somewhat complicated, but we're really excited about the potential and the opportunities that might exist with this. Before I go into community information exchanges, I just want to say, while CIEs are the electronic architecture, ideally what should be in place in communities is a concept that's called community-based care coordination. This is something that the executive directors have very thoughtfully worked through with the help of an outside consultant to come up with a white paper that has some themes, visions, and ideas. And really, community-based care coordination is an organized system of care across medical providers, behavioral health, social service, and other providers such as EMS. And the goal is to meet whole person care needs, including needs that are tied to the social determinants of health. Ideally, community-based care coordination includes things such as agreements among providers, such as business associates or MOUs. It's collectively designed. There are collectively designed care pathways that focus on some specific use cases, such for example, let's say people who are redirected or diverted from police into SUD. As well, it leverages community support such as peer supports, community health workers, and other resources on the ground. I'd also like to say that Healthcare Authority has put out a white paper on community information exchanges themselves. They're working to develop interoperability standards, which are technical standards that can be applied across the state. They are looking to leverage government funds through ARPA funds to try to support the development of a community information exchange or a healthcare information exchange, which is a little bit more comprehensive. So back to the CIE, this particular diagram contains some of the features that are part of community information exchanges. I will just say that not all these features are in every CIE. We'll explore some sample CIEs in the next slide, but some of the basic large features of a common community information exchange includes social need screening. And we've just gone through that, such as the Prepare tool that screens for particular social determinants of health. There can also be a bidirectional information exchange, which simply put is just the exchange, a secure portal to exchange communication between different providers. There's also the potential for risk assessment and analytics and metrics at a high level to monitor how the system is performing. So for example, there might be monitoring to identify what percentage of referrals ended up in a visit by the downstream provider. Collaborative care coordination is something that might be, that's something clinically is a little bit more involved, which might involve the exchange of care plans between providers. There also might be a unique patient record that's built into the community information exchange that can be shared across providers. Referral management is one of the very basic features of any and all community information exchanges. And it's just simply sending referrals from one provider to another. And finally, a resource directory lists the potential providers that are linked into the exchange so that when a referring provider is sending out to, say, for example, housing is listed within that directory. Let's go on to the next slide. This is just a sample of this very busy, very congested marketplace that continues to evolve. These are some sample community information exchange, health information exchange organizations. We have already talked to many of these or heard presentations from many of these, including Aunt Bertha, NowPal, Innovacer, Activate Care, 1 Degree, San Diego 911, Vision Link, Unitas, Healthify. I know that some of you on the call have also talked to some of these providers. Some of these have systems that are more built out than others. Some of them have more flexibility than others. I would say honestly that part of our trepidation and perhaps slow movement into this area is that we've kind of been looking for the right fit to what we see our provider organizations needing, as well as having the right amount of flexibility to adapt to what some of their needs are. And I'll stop there if anybody has any questions.
All right, I'm not seeing anything in the chat box, so thank you so much, Wes.
So one of the things that I wanted to make sure that we asked Wes to add that component to our learning collaborative today was I've heard in different calls with some of you that you are getting a lot of calls from some of those companies, and we just wanted to give an overview of how many are out there and create a context for you to kind of begin to understand this community information exchange world that we're finding ourselves in. It does provide a component of closing the loop. Many of you may have discovered that, but it looks like we'll probably be talking about this more in the future with Greater Columbia. And we really want to partner with you in helping to provide that care through the community and close the loop. One of the things that we have the pleasure of doing is working with Joyce Newsom with Washington 211. So Joyce has worked for over 30 years for the state departments in the UK and here in the USA, and in a variety of roles that include case management, program manager, and business marketing for the employment sector. Joyce works for People to People, People for People, a nonprofit in Yakima that is committed to improving lives and strengthening communities throughout Eastern Washington since 1965. Joyce's position at 211 and Mobility Outreach Manager, it causes her to be very active in the community. 211's mission is to connect people to a wide range of health and human services, especially during critical times. So Joyce is heavily involved in the Benton and Franklin community, serving on different committees and coalitions, and serving in the Leadership Council and Communications Committee for Greater Columbia Accountable Communities of Health, which is state mandated to review and positively impact the health needs of residents over 10 counties. What's really important, we're so delighted to have Joyce here, but we wanted you to hear about this resource that's available to help you with your patients who have identified a particular need related to social determinants of health. So with that, I thank you and welcome Joyce.
Thank you, Laurel. Can everybody hear me okay?
We can hear you good.
Great, thanks, Brittany. Appreciate that. Well, good afternoon to everybody, and thank you for this opportunity to talk with you all. I know, looking through the participant list, I know some of you personally. I know some of you are from the counties that we serve and are very well aware of 211. So I will keep this brief, but reminders are always good. And I wanted to have the opportunity to share that this resource can really help you in the work when you're screening your patients for social determinants of health and how to get them connected to those critical resources. So the first thing I would like to just highlight is that the 211 system is a national system. It is available in every state across the US, and it helps people in the communities that they live, in the towns that they live, get connected to the resources that are available. And so we play a key role in connecting folks to those services to really address their unmet needs. And it also gives us the opportunity to partner across multiple sectors to address those needs, to leverage funding in those areas where we see a need. We definitely have an impact in our counties where we can have those multiple partners. So what we know and what we have always understood through the 211 system is that patients or folks with unmet social needs, they do tend to be sicker. They visit the ER more frequently, and they do cost more to treat. And that's what we're all here today, to really look at how can we help that patient walking through your door? How can we help them to have a better access to their health through meeting their social determinant needs? And obviously, since the pandemic has started, we've really seen a further impact on those social determinant of health services. And as a result, we've seen worsened health outcomes of our vulnerable populations. And we're very well aware of that across Washington state and as a national system. And so we're always looking for ways to see how we can get them connected to those vital resources that they need. So let's break it down to Washington state. We have 7 call centers. My agency, People for People in Yakima, manages one of them, and we cover 14 counties in Eastern Washington, which many of you today are here representing those counties. Something that was new for us at the beginning of the pandemic was where the Department of Health at state level approached the 211 system to ask us to help manage their COVID helpline because they did not have the staff and the resources to do that, which we were able to pivot very quickly and do that, seeing that that was such a vital need to get folks connected to all information related to COVID in an accurate, timely manner. So we manage that helpline 7 days a week. And we've been doing that since March 13th last year when the pandemic started. And there have been some weeks that we receive up to 10,000 calls a day from folks in the community, especially around the vaccine rollout period. But many will phone us regarding COVID testing, a vaccine appointment, what phase are we in, how's this impacting my business? So there's been a lot of different needs that we've seen come through the community since this pandemic has hit. And we were able to hire and train a lot of extra staff to address those needs because so many people have been negatively impacted during this pandemic and have needed information and resources very quickly to manage and function. And as a result of those calls that come in, many of them referred over to the 211 helpline that we still manage Monday to Friday, 8 to 5. And that's where we're really addressing those social determinants of health. And, you know, our top 10 needs still continue to be the ones that were highlighted in the PowerPoint around housing, food, utilities, rent, transportation. So what I wanted to highlight today is that, you know, when that person is referred to the 211 system, and we hope by yourselves as community providers, that they do get to speak to a live person within 3 to 5 minutes. And that person will take their time. They go through some very intensive training. It's not just a referral system. They receive a lot of ongoing training to answer some very complex questions from folks. Some have very complex living situations. And so it might mean that we have to break things down, do some action planning with them, do some follow-up calls, but we are there to help them get those needs met. Our staff are bilingual. We have a translation line that allows us to communicate in up to 240 languages. And as an example, if I think Laurel or Brittany, if you could just show the first graphic to the group. I call it the MAT graphic. It just kind of gives you a sense of what happens when one person can phone 211 and how we really can meet the needs of that person. Yeah, it's not that one, sorry. It was a graphic I sent to Laurel yesterday, and it was called MAT, M-A-T-T. Sorry. It's kind of like a journey of one individual phoning 211 and the resources that he needs for him and his family. But I'll carry on talking, no worries. So when this one person calls, like I said, we are very aware of making sure that we're meeting all their needs. Somebody could phone us for one question, but with their permission, we're going to be able to screen them for other services. And some of the specialized services that we can help with is helping them to do their application to the SNAP Basic Food Program. And food insecurity is a huge issue in our communities across Washington state. And we are a master contractor on the eastern side with DSHS to actually take those applications on behalf of DSHS. And we find that many people are more comfortable to reach out to us because we're not a government department. They can phone in and be anonymous at first and just share the size of their household and their income. And then we can tell them if they're eligible within a couple of minutes. And then if they want to proceed, then we take the information and submit their application on their behalf to DSHS. And since the pandemic started, the governor has awarded the full maximum amount to families. So as an example, based on income, a family could have been receiving $32 a month on basic food or $100, but now they're receiving over $700 a month, regardless of the income that they have coming in based on that initial eligibility. And that's huge for a household. If they can have the assistance with food now, maybe they can use some of that other money to pay towards their rent or a utility bill, or even transportation to get to their medical appointments. And so we very heavily highlight that service, because many people think that they have to go through the DSHS system, but they can call us simply by calling 211. We also help with transportation needs. We have transportation specialists that look at all the resources in the communities that we live. We as an agency personally operate free shuttles throughout Eastern Washington, including our newest one that comes in from Othello, Cornell, into the Tri-Cities, that takes folks to medical centers and to the transit to connect to another ride, or to WorkSource for employment services once WorkSource is open. And these services are funded through different grants and contracts that we apply to that really help us in serving the community with those needs. So really the question today for you guys is, well, why else use 211? Well, we are that central point of access to social determinants of health. We are the expert on social needs in our local communities. And we can really help people get connected to those resources that are out there, because our database is comprehensive and current. In my outreach work here, since I've been working with people for several years, many organizations I speak to, they've invested a lot of money in printed directories, or they've created an app, or they've done an online directory. But the common feature amongst all of them is eventually they approach us to say that they don't have the staffing resources to keep those directories up to date, or once they're printed, they're out of date. And that has been amplified since COVID hit, because there have been so many changes in our community-based organizations and how they provide services, whether it's opening times or location move, or how to meet with them virtually to get access to those resources. And we have a very strong partnership with all of the agencies that list with us to keep that information up to date. So right now, just so you guys know, we have over 5,000 agencies listed statewide, but for Benton Franklin, we have over 180 agencies with over 700 different services. So if you let that number sink in, that's a huge amount of resources for any one individual to have by calling us at 211. And that's important because, like it was mentioned earlier in the PowerPoint, it can be very overwhelming when a patient comes in and ticks a lot of those boxes on the screening tool. And where do you start? Well, we have all of that information. And so we can be that helping hand with you to really help those patients get connected to those resources. And we can do follow-up calls with them. We don't have to address everything that day, because we are very aware of the anxiety and stress that comes along with trying to sort everything out that day. We can be an advocate for them. We can be on another call with them if they need to phone an agency and don't feel comfortable for what they're asking. So that really does help make that caller more comfortable. Each agency that lists with us, there's no charge. But we do expect them to provide timely updates on their programs and services. It really helps us and it helps the community, because we want to give out the most accurate information. But we do have a system in place to collect those updates as well. We, as a system, are guided by the standards established by the Alliance of Information and Referrals Systems. So that's across the 211 system in Washington State. All of our staff have to go through this intensive training, but that ensures that we have accurate resource data. There's my match graphic. Thank you. I think Chelsea was posting that. Thanks, Chelsea. So just take a quick look at this, guys, but this really shows you how 211 can work for one family. And I know a lot of you know about 211, but this is such a good graphic to remind us. So this is Matt's journey, who was a student living at home, and his father was injured at work, his back, was unable to work, and so was concerned about paying hospital and utility bills. And so they were advised to call 211, and we can help someone find the financial assistance to pay that utility bill, and also help people navigate the complexities of how to pay the hospital bills that can be quite overwhelming for people. Then we can follow up with Matt via a text, and maybe he mentions then that he cannot take his father to those physical therapy appointments that he now needs to go to because he's busy in class. So then we can help to access the father to free transportation. Excuse me, I've got allergies today. So as a result of that, there's some different resources that that family or individual may need throughout the situation that they're going through. And it can be in different ways that we communicate with them. It can be by phone, it can be by text, it can be by email. They can look online at our website for those resources, but it's there. It's there readily available for them 7 days a week, 24/7 to take a look at. Thank you for bringing that up, guys. I really appreciate that. I just wanted to also mention that, we capture a lot of data, obviously. Every social need that is expressed to us by callers to 211 and our visitors to the website, we actually collect that data through our 211 counts system. So website, if you want to bring that one up, then that was the one that was brought up earlier. And this is on our Washington 211 website. So we have this 211 count system. And if you click on the middle, there's a great little sheet there to help you to use it. We have found in implementing this, and this has also been available in other states, that over a third of the responses we get are from healthcare organizations looking for data around the social needs of their communities. And you can actually pull reports from this by zip code, by county, and it will give you the needs of what people are phoning 211 about. It's actually used, this online dashboard service, in 33 states, and can also help you guys with your health need assessments. So this is a great website to take a look at. And like I said, it's on the Washington 211 website. Another important piece that we do is we really help to identify gaps in service community planning or resources. So something that came up that I'd like to just quickly discuss is when the vaccine rollout occurred here in, the end of January, beginning of February, and that was rolled out to our seniors first. There was a lot of concern from seniors phoning our COVID helpline that they just did not have internet access or a printer. They didn't know how to navigate the face finder that was being used at the time, or even how to book an appointment. And then lastly, transportation. And a lot of them did not have the access to transport. They had before been used to either getting on a bus or having a friend or family member take them to where they needed to go. And now with COVID, they were very reticent to do that because of the exposure risk. So myself as a coordinator, we formed a coalition in partnership with the health department to really look at these needs. And we were able to address some of these very quickly with obtaining private links from the Department of Health to book appointments direct with seniors. And then in partnership with the Ben Franklin Transit System, they actually they decided for the dial-a-ride system that folks did not have to make an application if they needed to use that system for a vaccine appointment. Usually a dial-a-ride paperwork can take 6 to 8 weeks to process. So this was a huge win for our community, that folks could phone Ben Franklin Transit and either use the dial-a-ride system because they were a senior or they had mobility issues, or for others in our community who are lacking in transportation, they could use the Connect service, which is free. So that really helps us working closely with partners in our community that we hear very quickly through our 211 call line and also through the COVID helpline that we've imagined since March, what those gaps are in those social determinants. And we really try to leverage some funding where we can, but also collaboration is key with our partners to see what we can do to really provide some solutions to those barriers that folks may be experiencing. So just as a summary, we are constantly in conversations as well at a state and regional level about the CI systems and how we can definitely support the healthcare sector in helping to serve your patients with the screenings that you do. But in the meantime, how I can help is we can provide you a supply of 211 RAC cards to have available. Some like to have them at their front desk. Some like to have them in their orientation packets with the patient. I would be happy to do presentations to your staff to talk more about 211 for those of them that couldn't make it today. And then when we do open up any outreach events that may be occurring in the community, we are happy to come and support as well to share about the 211 system. And if there is time, we can show the video, but if not, I totally understand. So thank you.
Joyce, this is Laurel. We do have a few more minutes, but there's one thing that you and I had discussed in an earlier call, and that was that many of our provider organizations are actually listed in the as a resource in 211, and we want those to be kept up to date. So
Yeah.
do you want to say a little something about that?
Thank you. Yes. So yes, many of you looking at the list today, you are listed in our 211 system, and we thank you for that. And we make the referrals. However, the system is as good as the information is good. And so we do appreciate and depend on those partnerships from our community-based organizations and medical providers, etc., to give us any updates or changes as they happen. And there is a super easy way to do that now. So thank you for bringing that up, Laurel. If you go to our Washington 211 website and then go to Providers tab, and then go to update your resource. If you can go to update, yeah, perfect. So all you have to do now is type in, you can leave that there, contains, but on the second tab, the second field, type in the name of an organization. So let's do Lourdes because they came up. And yep, and then just hit search. Okay, and then if you see it says it's an active record, it gives an agency overview. The blue banners at the bottom show the programs and locations. So whoever is responsible for communicating changes, they can take a look at if their locations are correct, if their programs are direct. And as they look at each program and maybe there's been a change, all they have to do is fill out the request a revision tab in that empty box, which will take you into an email format. You'll just quickly give us the changes that will go through to our database team and they'll make the updates for you. It's that simple. So this is new for us and we're excited to start utilizing this. I think it was just loaded a couple of weeks ago. So yeah, you just put your information in and submit the changes. And it could even be, could you phone me? And then we'll take the information from you because we know it can be a challenge to get everything we need to get done. And we are happy to take the changes by phone if need be, or by another email, and we'll make the changes for you. So thank you for highlighting that, Laurel. I appreciate that.
Certainly, and I do think we have, Brittany, if you have the video ready, I do think we have time to play that.
Okay. It's just always a good little summary of what we can do. Thank you. And we trim it there because then it goes into a donation piece.
Okay.
And that's not appropriate for today. I just wanted to highlight this is how we can help all of our community to get connected to those vital resources and really support the great work that you're all doing in trying to help our community stay healthy or get healthy. So I really, again, appreciate the time. My email is on the first slide before this one. I left it on there. Yeah. So there is my email. Please reach out to me if you would like a supply of cards, or if you have any more questions, or if you would like me to present to your staff, I'd be happy to do so. And for those of you outside of Benton, Franklin counties, please feel free to still email me. I'll get you connected to the right staff member in the right area.
Okay,
Thank
and
you.
so we did have that one question and you've answered it. So resources in some of the smaller communities outside of Tri-Cities. So thank you, Joyce.
Yes, we just had a nice conversation with some folks from the Whitman area, and we're working with them right now. So, you know, we would love to have an outreach person like myself in every county, but it takes funding because we are a nonprofit. So, but we do the best we can. And, you know, since we've got used to this new normal with Zoom, we can definitely do a lot more now in contacting those smaller communities and reaching out to them to see what we can do to be of a support to them.
Okay, wonderful. Joyce, we appreciate you so much. Thank you so much for coming
Thank you.
with us today. Okay, we just had the one slide to mention, and then we will be having a break. We wanted to mention here our opioid resource networks. So as far as if you have an individual who is needing support, that they have a substance use disorder and are getting, if we can help them with getting into medication assisted treatment, patients, we can contact our area opioid resource networks. So there's Consistent Care and Blue Mountain Heart to Heart for Benton, Franklin, and Walla Walla County, and Palouse River Counseling in Whitman County. So the patient may need to be referred for wraparound services, which kind of touches on the aspect of resources that might be needed to help a person. So we wanted to make sure and mention that. And I know that we do have Lindsay is on the call today, and I'm not sure, I didn't see if there was anyone from Palouse River Counseling, but we're thankful for their partnership and work with us at Greater Columbia. Wanted to say too on that, we also would, as the navigators, if you have a particular interest, we would love to have them come and join us for one of our meetings together, our monthly meetings. And I know Consistent Care has been willing to join us for those. So just let your navigator know if you have an interest in having that happen. Thank you.
All right, so we are going to go ahead and take just a quick little 10-minute break right now. When we come back, we are going to be going into breakout rooms. So for breakout room 1, that's going to be for behavioral health. So if you are a behavioral health facility or identify with that, you'll go into breakout room 1. If you are a hospital skilled nursing facility, you will go into breakout room 2. And then if you are primary care, you can go into room 3. And if you do not identify as either of any of those, you can choose which breakout room you would like to go into. So we'll take a quick break and we will be back so it's 3:10 right now, so we will be back at 3:20. Yeah. All right, it is 3:20. I want to go ahead and we're going to open up the breakout rooms. So again, if you are for behavioral health, please go into breakout room 1. If you're part of the hospitals, skilled nursing facilities, please go into breakout room 2. And if you are for primary care, please go into breakout room 3. If you are not associated with any of these types, you can go ahead and pick which one you feel most closely represents your type of organization.
Hello, everyone. For those that are still here and not able to get into a room, you should see on your Zoom screen a button at the bottom of the panel that says breakout rooms or more. And then you should see a button. Once you click that, you should see options to join a specific room. If you do not see that option, just go ahead and type which room you'd like to go into, and I can help put you in, assign you to a room.
Chelsea, this is Laurel. I don't see that I'm in a room.
Do you not see the option on your Zoom? You don't see a breakout room notification at the bottom?
When I see it, when I click on it, it just says close all rooms or broadcast message to all.
Do you see the rooms laid out? Do you see the list of rooms, like room 1, and it should have people?
Yes.
So you to the on the header, you should see, or on the for whichever room you're going to, you should see the join button next to the room 1, and that's how you'll get in there. And then I'm gonna go back to the chat, everyone. I'm sorry, let me get you in there. I'm working on it. So Katie, you're going into room 1. We got Katie in room 1. We got Catherine. Catherine, where would you like to go? I'm putting Ken in room 1. Room 2 looks a little low, so maybe I'll start putting people in room 2.
Hi, sorry.
It's okay.
I'm Sarah Cash, and I'm the nurse navigator for Lord's Primary Care Clinic.
Perfect. Ashley?
Hi, I'm Ashley Walker, but I
All right, looks like we are everyone's returning slowly. Great. Perfect. All right. All right, looks like we pretty much have everybody back. All right.
Okay, are we all back now?
Everyone should be back.
Okay, thank you for breaking out, and hopefully there was some good discussion in that time that you had together. In our group, in behavioral health, we were kind of a quiet group, but one of the things that we discussed was it seemed like a common SEOH that was identified was the housing issue. And there was some positive mention of Oxford housing, to Oxford to help with housing. And then we did have a discussion of that as far as being something that helps. As far as best practices, there was really not a lot of mention, even though we know that there are lots of them out there in our behavioral health organizations. So how did it go in your breakout room, Sam?
Actually, it went great. Carol, if you don't mind, I saw you taking notes. Would you like to do a recap?
Yeah, that's the problem with taking notes. People know that you're taking notes.
I know.
It's very interesting. Housing is really popping up, I think, across the state and actually the nation. There's a real issue with having affordable housing. And we know that firsthand in the Tri-Cities that housing prices keep going up and up. And, people are being forced out of their housing when they can't meet the mortgage or because of the housing prices that forces people into rental situations, and a lot of people aren't able to meet the rents because as the housing prices escalate, so do the rent prices. So that's a real common problem across not only just our region, but the state and the nation in general. Other people mentioned also food insecurity. Childcare was an issue in several of the for several of the organizations, and low graduation rates. And we've seen that across Greater Columbia. Also, there are pockets where there's graduation rates that are lower than the state average. A lot of people talked about the young people being homeless. That's the population that tends to not want to go to shelters because they don't like having to give up their possessions. And so they do a lot of couch surfing. Catherine mentioned readiness, kindergarten readiness, and again, childcare.
And I also thought it was really interesting for Deb Watson in Whitman County, the barrier of having legal assistance in that particular area. So that Spokane, is the closest that they actually have that available resource, and many can't travel or connect.
Lourdes also mentioned verbal abuse as being a social determinant that they have picked up.
Okay. And then I think, Brandy, you had your hand raised at one point. Did you have something to add to the conversation?
That was accidental. Sorry about that.
Oh, no worry. I've done that myself. And then we also had another question in regards to Oxford House and wanting that someone not being familiar with that. I wondered if someone would be able to share in regards to that. They're working with Oxford Housing.
I'd be willing. My name's Todd. I'm an SUD counselor. Been in the field for a while. Oxford House is clean and sober housing. They're autonomous and self-supporting. Basically, what they do is they get landlords to volunteer a house and turn it into 5, 6, 7, 8 bedrooms. And you do your shared practice of you got to pay a portion of the rent, you got to clean the house, you got to give clean UAs. And they have their own bylines or bylaws. There is a regional, not office, but officers down in, for us, is in Clarkston, Lewiston area. And then they have, you know, the country's divvied up in regions, and they have kind of a hierarchy of leadership in that sense. And I think they're a nonprofit. I'm sure they're a nonprofit, but basically, you know, when they find a house, they just, if they meet criteria and it works, they join the Oxford program. But then it's just, you know, finding local people to live in the house and pay their fair share. I hope that describes Oxford. The video that they show is like a 60 minutes report from 1980 to describe the Oxford program. So.
Yeah, thank you, Todd. And Shireen has put a link in our chat to Oxford House, Washington State Association, for those of you who'd like to have it. Thank you so much. So let's hear from Brittany with the primary care group.
All right, well, we had a really great group, lots of good discussion. The main is very consistent with the primary care group. Their main issues were with housing and transportation. And then one of the slides also mentioned medications. And then we do have a best practice story to share. So I'm gonna go ahead and let Rhonda go ahead and share.
Thank you, Brittany. So I spoke up about supportive housing, and so I got voluntold that I get to share. Neighborhood Health is a community health center, and we started being a healthcare for the homeless provider back in about 2005. And as I shared, the first thing that happened was that our providers came to us and said, if you want us to make a difference in health, you need to help people put a roof over their heads. And so that's how we first started in getting into the world of housing, by getting involved with our continuum of care here in Yakima County. And we took over a housing project from an organization that was dissolving, and they were particularly serving people with medically fragile conditions. So we now provide about 80 units of supportive housing. But what's happened with the Medicaid waiver, along with, you know, creating these accountable communities of health, is there's another program called Foundational Community Supports, which is allows fee-for-service programs for supportive housing and supported employment. And as you know, I talk to a lot of community health centers about this, because lots of us, like we heard today, have housing issues for people that we help. And the FCS program, Foundational Community Supports, is Medicaid reimbursable services. It's specific to people have to qualify for this program. They're Medicaid recipients, but they have to have certain indicators, like a high PRISM score, if you're familiar with PRISM. For housing, they have to, if they've had an in-home, it's not just for homeless people, if they've had an in-home care provider, maybe they've lost them, or they've turned over because they've been difficult to work with. There's a few criteria, but we have a very active caseload for supportive housing. And in order to help with those programs, you can be a supportive housing case manager without providing the housing. We partner with the Housing Authority, with Catholic Charities Housing, with private landlords. We master lease some units. So you can do a lot of supportive housing without necessarily being the housing provider. And that's, I know, what a lot of primary care providers are reluctant to do, is to actually be the housing provider. So it's one of the things that I advocate for. In our world, we master lease a lot of units, because when we master lease, we are actually the tenant. And so we're in control of who gets to live there. And, you know, unlike other programs where, like the gentleman said earlier, Oxford houses are for clean and sober. And there are other programs that, you know, you can't get people into because they have bad credit checks. everybody we serve has bad credit ratings. So when we're the tenant, we get to decide who gets to live in units, but then we're also on the hook for if anything bad happens. There's things like the landlord mitigation fund that the state now has, so that if somebody does unusual damage, you can get reimbursed, or the landlord can get reimbursed for it. And so we help with that. But we've seen what a difference it can make if you give people a roof over their heads and then support them while they're living there, because the case manager stays involved with them throughout the time that they live there, as well as supported employment. And as I said to our group, you know, there's a lot of literature that shows that people live longer and healthier if they have housing, and they live longer and healthier if they have a job. So the FCS program is really worth looking at. And then if you don't want to provide the housing yourself, then partnering with some place like your housing authority or Catholic Charities Housing, the housing developers that have the housing, because they love those partnerships as well. Thanks.
Thank you so much, Rhonda. That's such great information to share. All right.
Great. Good sharing. Thank you, everyone.
All right, well, with that, we are coming to the conclusion of our Learning Collaborative. We have a survey this time. I'm going to go ahead and put the survey in the chat box for you guys. We would love to have your feedback to hear how we did and if you found this Learning Collaborative helpful. And then our next Learning Collaborative is scheduled for May 28th. But be watching for an email for confirmation in the next couple of weeks. We may be moving that. We didn't realize that that is the Friday of Memorial Day weekend. I don't know if that's going to be a problem for people or not. And this next Learning Collaborative is going to be on MCO rosters. So it'll be more specific to primary care. Anybody is welcome to attend, but the MCO rosters, that's more directed towards a primary care measure. So let me copy this link and I will put it in the chat box.
So we really appreciate your attendance and your input. We really would appreciate if you would it's a really short survey, if you would go ahead and do that. And we thank you for attending today.
Chelsea, can you help me? I can't get that link.
For some reason I can't. If you go out of PowerPoint mode, can you copy and paste it into the chat? Because I'm for some reason my PowerPoint's frozen up.
All right, let's see.
There you go.
There we go.
There we go.
Sorry about that, guys. I almost made it all the way to the end without any technical difficulties. All right, there we go. So if you guys please, we would love to hear your feedback in the Survey Monkey. I just put it in the chat. And with that, thank you so much for attending our Learning Collaborative today. I hope you found it useful.
Thank you.
Thank you.